Hello, Professor Nagler. Welcome to Hematology Frontier. We are very eager to hear about your pioneering work at Sheba Medical Center regarding CAR-T for autoimmune diseases. Let's dive straight into your clinical trials. As you expand the clinical trials in lupus and myositis at Sheba, what specific biomarkers are you monitoring to define durable remission? How does your team approach the unique safety considerations in autoimmune patients compared to the lymphodepletion protocols used in hematologic malignancies?
So this is very good question, and thank you. CAR T cells for autoimmunity is a different ball game than CAR T cell for malignancies, because the patients are younger and the patient don't have malignancies and the patient have not received chemotherapy. And also from a practical point of view, this is a much higher number of patients. And the patients are immunosuppressed with steroid and immunosuppressive drugs. So you are right, safety concerns are, I would say, important in CAR for malignancies, but even more important, very important in autoimmunity. And we discussed the issue of secondary malignancies and a few patients with T-cell lymphoma with integration of the vector into the T-cell receptor. And then the issue of fertility and the haemotex. So it's made that we may need less CAR T cells in autoimmunity, so it will be less toxicity. We may go without lymphodepletion, so it will be less toxicity. And as for the monitoring is done in Sheba by the autoimmune expert. So we monitor the disease by the clinical scales of lupus, and also the laboratory finding in lupus of the complement and double-strand DNA. We monitor the organs, especially in lupus kidney, but also can be the heart or the CNS. We monitor, like in hematology, the persistence and expansion of the CAR T cells. If we have toxicity, we may do a biopsy to see if the CAR T cell penetrated, the organ in which there is toxicity. So let's say CNS toxicity, if there is CAR T cell in the CSF, or if somebody comes with cardiac toxicity, we look where is the CAR T cells. So this is mainly. Also, I must stress that this should be a collaboration for now between hematologists that have, for now, more experience with CAR T cells and autoimmune, which knows the patient better than hematologists. I would say that in future, if the preliminary data that we have in CAR T cell in autoimmunity will hold, because till now, most of the series are small and we don't have big studies and we don't have two-arm studies, of course. But if this will become an approved or established treatment for autoimmunity, I would guess that the autoimmune physician will do it by themselves and will not need, hematologists, which in the beginning, of course, they learn from our experience. This is my expectation.
Moving on to the product characteristics. From Sheba's point-of-care experience and global practice, which manufacturing product features best suit autoimmune indications?
So, thank you. So, we from the beginning, from 2016, so quite early, and it's unbelievable that we are 10 years already there. We started with in-house academic CAR T cells, in which we produce our CAR T cells. At the beginning, it looked very complicated, but in China and all the other more and more centers know that now with the automated technologies that we have for the production of CAR T cell by several companies, like at least four companies in the Western, I would say, and maybe in China more. And the fast CAR, there are a lot is going on in the production of CAR T cell. Of course, we heard yesterday and in the meeting from Michel Sadelnight and others that we are using second generation of CAR T-cell, and they are much more efficient CAR T-cells. So this is one way. There is a big discussion between autologous and allogeneic CAR T-cells off the shelf. Of course, off the shelf is better, and the T-cells of the patient may be jeopardized, but I would say that the safety of the shelf CAR T-cell, mRNA CAR T-cell, is still, I mean, there are issues that need to be, at least we need to have more data and more studies in them. And then there is the big issue of the monoclonal, of the bispecific antibodies, even three specific antibodies, because this, after all, is easier than CAR T-cells. For the not academic department, instead of doing all this cell factory and producing the cell, you give antibody. There are issues with the antibodies, so the infection and the long period that you need to give the T-cell engager, as opposed to CAR T-cells that you give only once. This is hematological malignancies. I'm not sure what will happen in autoimmunity. The antigen is not clear, at least from CD19 and BCMA, but there is other more. We have even less data in neurological autoimmune disorders. I mean, scleroderma, some of the autoimmune diseases, we are not sure at all if what is the autoimmune basis of the disease. It's not like lupus. So, I mean, we are in the beginning of an exciting era, but we only in the beginning.